face every day. So that's kind of why we're going to go through this on the agenda. The overview of the analyzer itself, which is better in the CVOR, a measured hemoglobin or a measured hematocrit. Sodium protein changes and the 4 types of measuring for hematocrit. Anticoagulants, elevated leukocytes, and then I've got several case studies that should help you out. Then also the difference between conductivity and co-oximetry, and is conductivity really appropriate in the cardiac OR or CVICU? And then lastly, a recent paper that was presented that was done at the University of California, Davis on comparing conductivity and our ABL90. So the 90 operates on 65 microliter sample, that's like 2 drops of blood. You get a result in 35 seconds. The inlet is now automated, so you have an icon on the screen that you just touch for syringe. You get a lab quality total hemoglobin, measuring at 128 wavelengths. This helps correct for interfering substances in the patient's blood. You get 17 measured parameters. For those that think your point of care coordinator is a pain in your backside, the instrument actually is IQCP compliant and has been ruled exempt by several of the organizations. We also offer an optional battery and also wireless connectivity. It's intuitively easy to use. There's no maintenance, it's just replacements. It's available in multiple test cassette sizes, all the way from 100 to 900. Automated liquid quality control. This is why it's IQCP compliant. It actually runs liquid controls just like a human being would do through the exact same sample path that the patient's blood goes through. Smart chips simplify the installation. You don't have to scan anything, you just put it on. Onboard data storage, it actually has a built-in computer in it as well, and then full connectivity. So this is really the topic. Measured hemoglobin versus measured hematocrit. Which is the best in the CVOR? There are 4 types of measurements or measuring principles for hematocrit. The first is spectrophotometric or optical. That's commonly referred to as co-oximetry. The true terminology should be oximetry, but everybody recognizes it as co-oximetry. The actual hematocrit measuring principle that most of you are probably familiar with is conductivity. Then there's electrical particle counting. That's what the lab hematology analyzer does. And then centrifugation for PCV, or microhematocrit it was often referred to. That goes back a long way. It's still the reference method. It's putting the patient's blood in a little glass tube and spinning it down in the centrifuge, and then measuring the result. Hematocrit's an expression of the volume of red blood cells compared to the volume of whole blood. The volume of red cells in the whole blood has a direct impact on the characteristics of the blood to conduct electrical current, hence the term conductivity. So if you have a high RBC count, the actual conductivity value goes down. By measuring the conductivity of a blood sample between 2 sensors, it's possible to estimate the hematocrit level. Many analyzers use this conductivity method. The most common ones you'll see are the GEM Premier 3000, iStat, IRMA, and EPOC. Most of them are the single test cartridge type analyzer. It's simple and economical, but you have to understand the limitations of it. So what I've done here is broken it down into 5 factors that affect conductivity measurements. The red arrows indicate which way your hematocrit measurement goes based on this factor. So if you have changes in sodium and protein concentrations, it goes down. Anticoagulant types and concentration also make it read low. Use of volume expanders will make it read low. Increased concentration of leukocytes will make it read high, and increased patient lipid profiles will also make it read high. And for the most part, anybody that's in there having a cabbage done, their lipid profile is already probably off the chart. So during bypass, you guys know you're connected and you're circulating large quantities of cardioplegic solution through the body, oxygenating the blood and removing carbon dioxide. Cardioplegia by itself is a protein-free saline solution with high concentrations of electrolytes. But the hemodilution effect increases the conductive properties of the blood. Under these circumstances, the measurement method will report results that are different and almost always lower than those of other measuring technologies. So conductivity versus the electrical particle counter, spun crits, or true full measured co-oximetry will always read higher. This was a study, and I'm not going to go into all the details, but it's referenced there so that y'all can look it up if you want to. It shows the difference between that stat crit analyzer versus the measurements pre and post for packed cell volumes and to the lab for the Coulter counter. It said, the synopsis was, conductivity will report falsely low readings where plasma has been replaced by crystalloid. On the anticoagulants front, various anticoagulants, lithium, heparin, or sodium, have the ability to change the cell morphology, and it's due to osmotic changes of the cells. Hence, large variations in heparin concentrations, whether lithium, sodium, or potassium, will induce significant changes in the conductivity hematocrit measurement. The elevated leukocytes, we already talked about. It could be, if they're running, have a high white cell count or running infection, their incident of error could be as much as 11%. This is a reference done at the Mayo Clinic back in 1999, where they did it on pediatric CPB procedures. The error showed up as soon as that total protein was less than 5 grams per deciliter. If it was in the normal range, it was fine. At UConn, to avoid inappropriate blood transfusion, their conclusion was, based on hypoproteinemia or hemodilution, hemoglobin hematocrit testing should be performed using optical measurements or a lab-based hematology analyzer. So, is co-oximetry really accurate? This was Dr. Shapiro's quote. He's like the father of respiratory therapy. He wrote almost all the textbooks that RTs learn in school. He said, co-oximetry is the most accurate method available for measuring the 4 clinically relevant hemoglobin moieties. Now, most of the time, you guys don't care about carbon monoxide hemoglobin or methemoglobinemia, some of the dysfunctionals. You're only interested in the functional part of the hemoglobin molecule and the heme molecule. But he said it should always be used as your reference method. There's many references to inaccuracies, limitations during cardiac surgery. There's no evidence to dispute its ability to accurately measure levels of hemodilution during CPB. So when you measure with a true oximeter in your blood gas analyzer, you should get lab quality results. You shouldn't need to be sending CBCs constantly to have it checked down in the lab. So the conclusion here from this study was conductivity measurements provide accurate hematocrit results for physiologically normal subjects, but not for intensive care or surgical patients. I know this is pretty busy, but there's the biggest takeaway on this one is that you can sometimes, depending upon your protocols for cutoffs, you can be off anywhere from 1 gram per deciliter in hemoglobin or up to 3% hematocrit. That makes the difference between whether you give a unit of blood or not if you're at that critical threshold. This is the UC Davis study, and if anybody wants a copy of this, we have it in our booth. The takeaway here was this. They compared 60 patients through EPOC, ISTAT, and the ABL90. In 20% of the cases, so it was 12 actual cases out of 60, they gave blood when they didn't need to because of false results with EPOC and ISTAT. So in conclusion, when using point-of-care analyzers for all cardiopulmonary bypass and CVICU patients, the only accurate, reliable method to determine hemodilution and establish safe transfusion thresholds and better patient outcomes is using full co-oximetry. You want a measured hemoglobin, not a conductive hematocrit. Questions?